managing heart failure in CKD population. The triple family, which we'll discuss in our discussion also, the hypotension, hyperkalemia, and renal impairment. Not only renal impairment, but the worsening of renal failure is again a very important factor which we need to consider while treating our heart failure patients with chronic kidney disease. So this hypotension, hyperkalemia, and renal impairment results in treatment dose lowered, medication discontinued, but they don't tend to be goes very well with our patients. So here is a chart showing which drug we can use at what GFR. So as I mentioned, if GFR is more than 60, we can initiate with cortical therapy. If eGFR is between 30 to 60, we can initiate with triple therapy that includes your beta blocker, SGLT inhibitors, and RNAs. But these SGLT inhibitors are not indicated till date for GFR of less than 30. We have some studies in pipeline where we are using this molecule in ESRD population as well, not for glycemic benefit, but for cardiovascular benefit. But till now, we have recommendations till 20 ml of GFR. If GFR is below 15 to 30, we can start with triple therapy that includes your beta blocker, SGLT inhibitors, and ACE inhibitors. But again, we need to monitor serum potassium and eGFR. But if your GFR is less than 15, or if patient is dialysis dependent, we can continue with beta blocker. If patient is already on SGLT2 inhibitors, we can continue and other molecules like isosorbide nitrate. Now, when to titrate? What we need to monitor is systolic blood pressure, GFR, and potassium. So if your increase in serum creatinine is by less than 50%, if your potassium level is less than 5.5 milliequivalent per liter, and there is no symptomatic hypotension, we can titrate RNA or ACE inhibitors to maximal dose. But if any of the things occurs, like if rise in serum creatinine is more than 50%, if your GFR serum potassium is going beyond 5.5, we need to assess for any other cause leading to this condition, or we need to decrease the dose or stop the medication. If your heart rate is more than 60, then we can again titrate the beta blockers to maximal dose. But if heart rate is less than 60, we need to decrease or stop the beta blockers. My cardiologist friend will highlight on these things.